morning, myself Dr. Aparna, Assistant Professor of Cardiac Anesthesia in UN Mehta Institute. Today I am going to present about Transesophageal Echocardiography of Congenital Heart Disease, that is regarding Tril Septal Defects and its Anomalies Part 2. So what we are going to discuss is atrial communications assessment by TE. Anatomy of atrial septal defect or patent foramen ovale will be seen in the size and location of the defect, septal ribs, septal anatomy, direction of the atrial level shunt, drainage of the systemic and pulmonary veins, atrial chamber size, Doppler assessment of the atrioventricular valves, that is regurgitation or stenosis, mitral valve anatomy, assessment of possible pulmonary hypertension, estimation of right ventricular or pulmonary artery systolic pressure by tricuspid regurgitation jet velocity, pulmonary artery diastolic pressure by pulmonary regurgitation and diastolic velocity, configuration of interventricular septum, identification of other associated congenital cardiac lesions, ventricular chamber size and systolic function. Coming to the pathologies, thrombus prior to the cardioversion in the atrial fibrillation, patent foramen ovale, paradoxical emboli, atriopulmonary connection, atrial appendages, cord atrium, and primum ASD, secundum ASD, coronary sinus ASD, superior and inferior sinus venosus ASD, and connection of SVC and IVC. So normally we will see TE views of interatrial septum is mediasophageal 4-chambered view, mediasophageal RVOT view, bicaval view, and right upper pulmonary vein view. Coming to the ostium secundum, it is seen in mediasophageal 4-chambered view with slight rightward shaft rotation. Color flow imaging confirms pressure and direction of the interatrial shunting and is verified by pulse wave Doppler. Slight probe withdrawal may be required for visualizing small superior secundum and small inferior secundum defects. In this figure you can see it is a ostium secundum ASD and it is a mid-esophageal right ventricular inflow outflow view demonstrating almost 1.4 cm of secundum atrial septal defect. And the B figure it is showing mediasophageal bicaval view showing secundum defect in the area of fossa ovalis. And this is the ostium secundum RV inflow and outflow view. You can see in this RA and LA atrial septal defect in 60 degrees angle. And coming to the ostium primum, in this you can see two figures. Mediasophageal 4-chambered view with color flow Doppler. It is demonstrating, in this first figure, it is demonstrating two jets of mitral regurgitation. One is originating from the medial area of the cleft and a second from the more central jet of the MR was from the coaptation defect as a result of annular dilatation and not from the cleft. Note also that both atrioventricular valves originate at the same level of the center of the heart. And the B figure, it is the transgastric basal short axis view of a cleft of mitral valve. The cleft is clearly seen in the anterior mitral leaflet. Ostium primum, this is mediasophageal 4-chambered view of ostium primum showing RA, LA and that arrow one it is. Coming to the coronary sinus defect, slight advancement and retroflexion of the probe will allow for visualization successively of coronary sinus as it courses across posterior AV groove. In this you can see the figures. It is a 2D TE of unroofed coronary sinus. It is demonstrating 2D image demonstrating enlarged coronary sinus with unroofing communication with LA. In this you can see the arrow. And in the B and C figure you can see color flow Doppler into the coronary sinus from the LA into the RA, creating an interatrial communication through the unroofed coronary sinus. And in the D figure you can see 2D imaging demonstrating it is an enlarged coronary sinus with unroofing communication with LA and color Doppler flow into the coronary sinus from LA into the RA, that is B and E figure. superior sinus venosus defects. Withdrawal of the probe in the mid-esophageal 4-chambered view above the level of fossa ovalis, it demonstrates superior aspect of the interatrial septum, superior sinus venosus defects as well as SVC in this cross section. Anomalous drainage of the pulmonary veins as they enter the SVC can be seen in these views. So, in this you can see superior sinus venosus ASD, that is from the left atrium and again connecting to the superior vena cava, and this one right atrium, and then in the B figure you can see inferior sinus venosus defect, entrance of the IVC you can see. Then coming to the pulmonary venous drainage, images representing 3 key views for assessment of ASD by TE. Short axis views are critical for the assessment of aortic rim and the device interaction with the aorta. Bicaval and the long axis views are the critical for assessment of the relationship of the device with the roofs of the atrium. So, in this you can see the atrioventricular valve rim and the posterior rim and the aortic ring you can see in this ABC figures. And the TE view from the upper esophageal short axis view, it is demonstrating right pulmonary veins at 0 degrees with without and with color Doppler without and with color Doppler at 60 degrees. In this you can see right inferior pulmonary vein and right superior pulmonary vein in the A figure, and it is a color Doppler view. And again C figure you can see left inferior pulmonary vein and left superior pulmonary vein of that contrast D in color flow Doppler view. And this is also you are able to see left upper pulmonary vein, and this is B figure, it is the right upper pulmonary vein, and this is the 4-chambered view showing atrial and atrioventricular valve rims. Basal short axis views, it is the A figure is a basal short axis view, and B shows the atrial and the aortic rims, and the C figure it shows LA and RA, and shows the superior vena cava in IVC rims. For the optimal device placement, the rims should be adequate, at least 5 mm and supportive. The size of the ASD has to be seen in all the planes to decide the size of the ASD device. The same D figure has to be viewed on the color Doppler to ascertain the flow and the visualization of the additional defect. And in this figure you can see ostium primum and ostium secundum on transesophageal echocardiography. You can see from this one left atrium and right atrium, one superior and inferior figure, it is showing one is ostium primum and one is ostium secundum. And the patent foramen oval, TE of patent foramen oval in bicaval view with color Doppler, thick muscular ridge of superior limb forms an incomplete partition that overlies ostium secundum, resulting in foramen oval. In this you can see A and B figure, one is without the color Doppler and with the color Doppler. Fossa ovalis with patent foramen oval. Excessive mobility of the fossa ovalis with the associated patent foramen oval. Septum secundum, it forms concave shaped superior margin of the foramen oval and it forms limbus of fossa ovalis. Septum primum forms valve of fossa ovalis. In this figures you can see the fossa ovalis with patent foramen oval. And this is the color flow Doppler view of patent foramen oval. And these are the 3D TE views representing views and anatomical landmarks in an atrial septal defect. So in the figure A you can see one is the right atrial and the left atrial end phase views, and the B it is another example of RA and LA end phase view, and C it is the transgastric sagittal bicaval view and posterior perspective, and D is the posterior aspect views demonstrating variable alignment between septum primum, that is in this figure you can see S1, and the septum secundum S2 over the cardiac cycle, and one is the left one alignment between the septum secundum and S1 components, mild malalignment and more malalignment between the septal components. As this malalignment increases, size of the interatrial communication increases in the size. In this you can see the asterisks where the malalignment is gradually increased. In the orientation icon, blue one in this it designates y plane, and the down one it is there x axis, y axis, and again one more is the z plane. According to that, we'll say this one 3D TE views. And this is ASD of non-secundum type. So A figure, it shows primum ASD. One is the RA end phase view, 4 chambered, and LA end phase view. The ASD one is located at the apical inferior margin of the atrial septum, with the atrioventricular valve at its lower margin. Long axis of the defect is oriented in an anterior superior to posterior inferior plane. Note in the 4 chambered view that AV valves are coplanar. Coming to the B figure, it is superior sinus venosus ASD short axis and long axis views. The superior sinus venosus ASD is located at the junction of the SVC to the atrium, and the SVC overrides the defect. C is a longitudinal view of the typical superior sinus venosus ASD with anomalous connections of the right pulmonary vein to SVC. Note that the SVC overrides the ASD. In this you can see that asterisk. And coming to the D figure, it is a longitudinal view of typical inferior sinus venosus ASD. Note that the IVC overrides the ASD. And the E figure, inferior sinus venosus ASD end phase views from the RA and LA perspective. The defect is located at the cavo-atrial junction. There is also an ASD2 is present, and anomalous connections of the right pulmonary vein to the IVC are often present, but not in this case. And F figure, you can see demonstration of a common atrium in a complex heart defect with right dominant atrioventricular septal defect, DORV, and RA isomerism. There is a band of tissue that traverses the common atrium and no other atrial septal tissue is present. This collection of anatomical features is common in this complex anomaly. The AV valve is directed into the RV. 3D full volume view with frontal cropping showing common atrium which is transversed by a thin band. In this you can see that arrow 1, it is a thin band of tissue. 3D zoomed mode, right sided end phase view of the band across the common atrium, and one more is a corresponding left side end phase view. And the G is a coronary sinus ASD 4 chambered view with a left anterior oblique perspective. The defect is oval in shape and located near the AV junction. RA orifice is an enlarged coronary sinus orifice located in its usual position, and LA orifice is due to complete or partial unroofing of the coronary sinus into the left atrium. AV valve relative positions and anatomy are normal in contrast to ASD work. Then 3D TE view, in this you can see the images of mediasophageal short axis view of a PFO during the saline contrast study. The PFO exit into the LA is apparently blue. In this you can see the blue arrow. This is performed to help localize the size of bubble entry into the LA and not to quantify the size of the shunt. And from A to C you can see progressive saline contrast microbubbles crossing through the PFO into the LA. And 3D TE of multiple ASDs, white arrow, it shows Swiss cheese configuration. So A, it is a bicaval view. You can see 2 ASDs from left to right in a color Doppler, and B, it is the end phase zoom view from RA demonstrating ASDs are present, and zooming of minimally, and the C figure is zooming of minimally invasive surgical repair with single pericardial patch. And this is the transcatheter closure. Biplane imaging performed during the percutaneous transcatheter closure, imaging of multiple planes simultaneously. In this you can see aortic rim and superior rim is seen in the left arrow, and device interaction with the aorta and the atrial roof can be assessed simultaneously. And this is the 3D TE views of the devices. So, intraprocedural 3D TE view, it provides superior visualization. In this you can see wires, catheters and the devices in their relationships to the neighboring structures in a format that is generally more intuitively comprehended by the interventional cardiologist than 2D echocardiography. In this, an ostium secundum ASD has been closed with an amplifier device under real-time 3D TE guidance. All views are shown from the LA perspective. So, LA in this A figure you can see LA disc of the device opening into the LA, and B is the view showing continued opening of the device. C is undersized device with a residual defect. This device was removed and a larger closure device was used. And this is the cor atrium. This is one of the pathology you can see in the left atrium. So, in this you can see that anatomical figure also. So, this is the TE of cor atrium. Abnormal septation of the left atrium is a cor atrium sinister, and the abnormal septation, if it is present in the right atrium, then it is cor atrium dexter. And the septum can be like complete, incomplete or fenestrated, and anatomical variations are also present like diaphragmatic, hourglass and tubular type. Coming to the thrombus, in this you can see zoomed bicaval TE view of the thrombus in the yellow arrow. It is attached to the interatrial septum at the left atrial septal pouch. This might represent a thrombus in the transit crossing a patent foramen ovale, that is paradoxical embolism, or an in situ thrombus in the left atrial septal pouch. Left atrial appendage with sac. Transesophageal observations of left atrium and left atrial appendage obtained via linear endoscopic ultrasound. It revealed left atrial appendage thrombus, and B, it is the left linear endoscopic ultrasound. It showed spontaneous echo contrast in this also in the both left atrium and left atrial appendage, and this is also thrombus in the left atrial appendage. Thank you.